A 19-year-old Caucasian woman was referred to our clinic for evaluation of amenorrhea. This was an unusual presentation for the investigation of primary amenorrhea. She had been investigated for thyroid dysfunction as the presumed cause of her amenorrhea at the age of 14 years. Her serum thyroid hormone levels were normal at the time, with thyroid stimulating hormone TSH level of 1.4 milli international units per liter. The normal ranges for that is 0.4 to 4.2 milli international units per liter, and free thyroxine FT4 levels of 14.6 picomoles per liter, normal range 12 to 2.4 picomoles per liter, and no further investigation was undertaken. There was no family history of thyroid cancer. We obtained informed consent from a patient for diagnostic procedures and treatment, as well as consent for inclusion of her data in an anonymized scientific report. A physical examination showed that development of sexual characteristics were not entirely normal, although the development of secondary sexual characteristic was normal. Investigation included abdominal and pelvic ultrasonography and magnetic resonance imaging, MRI. Type 1 MRKH syndrome was suspected because of the total absence of the uterus and fallopian tubes. She had a vaginal remnant measuring 1.8 centimeters in length. Both ovaries were normal and no other structural abnormalities were found. Examination of the thyroid gland showed enlargement with a mobile 2.3 centimeter diameter, solid nodules in the left lobe. There were multiple mobile left lateral cervical lymph nodes with a maximum diameter of 1 centimeter. Thyroid function testing showed normal serum levels of TSH of 1.8 milli international units per liter and anti-thyroid peroxidase antibodies less than 34 milli international units per liter. Thyroid ultrasonography showed a hypoechoic left thyroid nodule with increased central vascularity. According to the current guidelines for evaluation of thyroid nodules, fine needle aspiration biopsy, FNAB, was indicated. The FNAB showed high cellularity in the nodule, and cytological examination showed follicular lesions that were classified as THY3 according to the latest classification system. TC-99M Pertechnetate thyroid scintigraphy 185 MBQ showed a nodule in the left lobe with no metabolic activity, code nodule. The combination of clinical features, cytological examination findings, and imaging findings led to a diagnosis of nodule Gautier, highly suspicious for a malignancy. She was referred to our surgery department for total thyroidectomy with selective lymph node dissection. Pathological examination of the surgical specimen confirmed a 2.1 centimeter diameter papillary thyroid carcinoma in the left lobe with invasion of the thyroid capsule. 3 of 16 removed lymph nodes were positive for cancer. The cancer was classified as stage 1, T2, and 1A MX, according to American Joint Committee on Cancer/Union International Contre Les Cancer Staging System, 7th edition. The prognosis: thyroid carcinoma and Mayer-Rokitansky-Koester-Hauser syndrome.